So we move on straight to the second leg of the presentation, and that's going to be on metabolomics, a chemical microscope of health and disease. And to do that is none other than Pharm Haastrup Adeyeye. And before he comes up, I'll be doing a brief introduction of our presenter. Pharm Adeyeye is a pharmacist, a product of the prestigious Obafemi Awolowo University, Ile-Ife, Nigeria, and is a PhD candidate at the University of South Alabama, where he joined Dr. Langley's lab in 2023. He has made significant contributions to science and received numerous awards, including the Dean's Postdoctoral, the Dean's Pre-Doctoral Fellowship Award, and the Godwin Emerging Scholars Endowed Award. Adeyeye's career goal is to advance bioinformatic methods to integrate multi-omics data sets with other scientific evidence for diagnosis, comprehensive characterization, and personalized treatment of human diseases. Additionally, he aims to leverage bioinformatics approaches for translational research. And after his PhD, he plans to pursue a postdoctoral fellowship to integrate artificial intelligence with bioinformatic pipelines. He looks forward to becoming a principal investigator conducting independent research on mitochondrial-related human diseases with the goal of making discoveries that can improve human health. I'll encourage us to sit back and get as much as we can from Adeyeye Haastrup. You're welcome. I'm Adeyeye.
Thank you so much.
Let's encourage him with an applause.
Can you see my slides,
using
please?
the icon.
Yes, we can see yours, right?
Oh, okay. So first of all, I would like to say thank you to the hosts who introduced me. Thank you so much. And I also have to, I want to express my appreciation to Dr. Olakunle Jayesimi, who has been my mentor for over 10 years. I've learned a lot from him, both at the formal and informal level, and he has always been an inspiration to me. And that's the founder of MetabHole. And without much ado, I would like to go to get into the presentation. And again, my name is Adeyeye. So I'll be talking about metabolomics as a chemical microscope of health and diseases. And speaking of that, when we think of microscope, what comes to our mind? We think of a device that we can use to actually, magnify an entity or a particular thing so that we'll be able to see it in a greater detail as well as to be able to measure it. So in terms of metabolomics, is actually a tool that we use to magnify chemicals in the body or in a system so that we'll be able to know it in greater detail, as well as to be able to quantify it and see the differences. So this has been used over the years in health and also in diseases. And for that, metabolomic samples, samples that we collect for metabolomics profiling ranges from, these are just a few examples in humans. Sometimes, we collect the saliva, we collect fecal material. Sometimes we go for the urine, blood, serum, and solid tissues. And now, there are two areas of metabolomics that are actually making a lot of waves, which is looking into sweat and breath. And there is an emerging concept that we call breathiomics. which talks about the metabolomic classification of metabolites that are in breath, which is quite informative in serving in discovering and detecting biomarkers of diseases. So, and currently in different databases, we have over 200 and over 200,000 metabolite that has been characterized in humans. That's actually a lot. And just like Dr. Annelise said, there are different omics that are in use. Like we have genomics, we have transcriptomics. But when you think of metabolomics is actually the closest to to phenotype, whether in plants or humans or sea creatures or whatever whatever living system you are interested in. Metabolomics is the closest of all the omics to the phenotype. So just to give an example of what I mean by a chemical microscope, when you use the scope of metabolomics to look into human sweat, in a healthy human, you will see that a healthy human sweat is not just water, and it has ions such as the sodium, the chloride. You will find other salts, you will find glycerol, you will find lactates, you will find other important ions. In fact, with the metabolomics, we're able to detect that skin can also serve as an organ of excretion, whereby you can excrete urea through sweat. Now, in a disease setting, for example, in Cushing syndrome, metabolomics, you can use it to detect substances such as cortisol and excessive sodium chloride from the sweat. And you might be able to actually have evidence that, oh, this person is likely to have Cushing syndrome, combined with other clinical evidence that will form a stronger diagnosis that, okay, this person definitely have Cushing syndrome. This is just a simple example of application of metabolomics. And metabolomics in health. And one of the areas that has benefited a lot with metabolomics is actually characterization of human microbiota, whereby we study the relationship between human microbiota and different organs in the body. For example, we have the gut-brain axis, which talk about how microorganisms in the gut, that is in our digestive system, can actually influence brain function. And we have the gut-heart axis, we have the gut-liver axis, we have the gut kidney axis, and so on. And we've also used metabolomics to study human bioenergetics. Different physiological areas of humans. And we've also metabolomics is being used extensively currently in the area of studying the immune system, especially immune interaction in the body, immune response, and even organ-specific metabolism. For example, talking about organ-specific metabolism, we now understand that different organs metabolism, even though they are in the same body, can be starkly different. For example, when we talk about through metabolomics, we're able to understand that brain actually uses glucose extensively during rest as its bioenergetic preferred precursor. Meanwhile, the heart is totally different. About 60 to 80% of energy supply that the heart actually uses during rest is derived from fatty acid, not from glucose. So with metabolomics, we're able to make this characterization of how human physiology works. And metabolomics also has been used in nutrition, in characterization of vitamins and its metabolites, and also in hormone regulation. And that's actually a huge area of metabolomics right now. And um, of course, metabolomics is currently, and in fact, for the past 30 years, has been used to characterize different metabolic regulation in health, in human body, regarding amino acid, sugars, the saccharides, fatty acid, and the lipids. And of course, environmental toxicology, we want to understand how the substances we use in our environment actually affect our metabolic systems. And for example, we know that through metabolomics, we're able to detect the effect of some substances in plastic, such as bisphenol, the phthalates, and ferroates, etc. But now we understand that it even goes beyond that. That, for example, if everything you do throughout the year is drink water from plastic bottles like this, or you use a lot of plastic, you'll be ingesting around 39,000 to 52,000 microplastics into your system. And through metabolomics, we've been able to characterize their effect on hormone disruption and different things. So, and studying epigenetics and epitranscriptomics, which talks about the effect of the environment on genetic manifestations. This area has benefited a lot from metabolomics as well, where we look at how does the environment, like the lifestyle, the diet, the toxins, how do they actually influence our body system? How do they determine what we do and what we don't do, or what our body expresses? So these are just few examples of importance of metabolomics in health. And of course, metabolomics is used a lot in disease conditions. For example, cancer metabolomics is now a very prominent area of cancer investigations now, where we've come to realize that cancer cells actually have different metabolic profile to normal cells, and even different within a particular tumor, different populations of cancerous cells actually have their distinct metabolomic profile. So that has also helped in guiding therapeutics, and also to discover therapeutic targets of what we can target in cancer to improve treatment. And metabolomic syndrome has also been an area that has benefited from metabolomics, where we characterize different metabolomic dysregulations in those that have the illness. And cardiovascular health, recently we get to learn that uh, there is a connection between our digestive system and the heart, and especially in the area of having diseases such as cardiovascular disorder like atherosclerosis, like atheroma, and even heart attacks. There is this particular compound produced by this metabolite trimethylamine is produced by the microbiota in the gut, and once some specific microorganisms are present, they produce this particular metabolite, and the metabolite travels into the liver, is converted to the toxic derivative by oxidation, and then goes to the heart and promotes accumulation of fat in coronary artery, which actually can lead to the blockage of the heart vessels, and eventually people can get heart attack from that. And mental disorders, now we understand that the importance of the microorganism in being present in our guts, and their relationship with our health, especially mental health. This microorganism produces substances like neurotransmitter precursors, and some of them even produce neurotransmitters directly, like GABA, like serotonin and dopamine. And in fact, gut dysbiosis has been linked to some mental disorders such as depression. And when in patients that have the gut dysbiosis, when normalcy was restored in their gut microbiota, they were actually lifted out of depression. So, and of course, pharmacokinetics. This is a very important area in pharmacy and even to medicine, where we profile drug actions in the body, like drug system, drug metabolism, and see, even assess drug interaction using metabolomic investigations. And just to cite an example of use of metabolomics in gaining novel insights in disease mechanism, I'll be sharing one of the areas of research that I personally have embarked upon. In my lab, we've used metabolomics to profile COVID, dysregulation in COVID-19 patients. We've used metabolomics to study sepsis. We've used metabolomics to study acute respiratory distress syndrome and acute respiratory failure. This is one of my research that I conducted currently in my lab, and Just to give you a little bit of background, acute respiratory failure affects around 20 million people yearly, of which the mortality is around about 8 million people throughout the world, and about 50% of these patients are admitted into the ICU. But what we are concerned about is actually the survivors. When people survive acute respiratory failure, almost half of those that survive acute respiratory failure will have physical disability after surviving acute respiratory failure. So this is a huge problem because if they are if they have physical disability after having acute respiratory failure, it means they won't be able to resume back their normal jobs. Bills start piling up. They won't be able to enjoy their life. The quality of life their life decrease drastically, and this physical disability is usually characterized by feeling very tired, feeling lethargic, and feeling having fatigue. So we actually thought in our lab that okay, and also, American Thoracic Society, which is a huge organization of physicians, actually identified this area of physical disability in survivors of acute respiratory failure as an area of high priority for research. So in my lab, we thought that if these patients are experiencing fatigue, then probably it may have something to do with dysregulated bioenergetics. That is, their bioenergetics is dysfunctional. And then what we did was we recruited acute respiratory failure patients, and we conducted what we call short physical performance battery test on them, and on the survivor. So this test actually measures different parameters like gait speed, the balance, and and posture. So, and this test has been used, is applicable clinically in the sense that it is used to assess who is at risk of falling, who is at risk of even dying, who is at risk of having poor quality of life, who is at risk of having physical disability. And we divided those patients into, those with poor scores and those with good scores. That is, those who have good physical performance and those who have poor physical performance, of which all of them are survivors of acute respiratory failure. But initially, when they were in the ICU, we actually collected the blood samples of those patients. We collected their blood samples on day one when they were admitted into the ICU and still very, very sick with acute respiratory failure. And on day 5, when they've, of course, improved based on the hospital treatment and at the point of their discharge from the hospital. And what we are trying to bring out is that the mechanism through which these people come up with to have a physical disability is not known. At the point of discharge, the physician actually check all the parameters that, okay, these patients, whether checking the Apache score or the SOFA score, they are okay. Whether checking their physical activity, they are very all right. Like they are ready to be discharged and, go back to their normal activities. But usually between days or between few weeks or between few days to few weeks, we start seeing that they start seeing that some of those patients actually have physical disability. They can't resume back their work. And collecting their blood samples on these 3 time points will profile the metabolites using mass spectrometry, and we did the metabolomic analysis to see, okay, since they look okay at discharge and they check all the points with the clinical evaluations that they are ready to go home, they are fine. But why do they actually, what's the mechanism behind them developing physical disability after being discharged from the hospital as being good? So the metabolomic results that we found at day 1 is we saw bioenergetic dysregulation on day 1, and that has to do with amino acid metabolism. And of course, that wasn't unexpected because we've seen that before. But on day 5, when we see there's still some dysregulation, metabolic dysregulation in their system, but not as much as they had in day 1. And, of course, that's also expected because the treatment that they receive from the hospital has to count for something, right? So at discharge, when they were okay and ready to go home, and you expect that, of course, they should even have better improvements in their metabolomic signatures. But to our amazement, interestingly, that was actually when they had the highest level of metabolomic dysregulation. And this metabolomic dysregulation was only found in those that will go on to have poor physical function after discharge from the hospital. Those that had good physical function did not have this metabolomic dysregulation at discharge. Meanwhile, all of them at discharge, they look okay, they look happy, they were ready to go home. But the clinicians can only make clinical evaluations based on what they could measure in the hospital. But with the help of metabolomics, we're able to see that this subset of patients that actually went on to have poor physical function actually have bioenergetic dysregulation at the point of discharge, compared to those that had good physical function down the line. And we're able to know the nature of the bioenergetic dysregulation, that it has to do with the mitochondrial, and it has to do with the TCA cycle and even muscle metabolism. When you think of physical function, if I want to move now, I'm using my muscle to move, right? So I'm able to move because my muscle metabolism is optimal, or probably is functional. But if there is a dysfunction, I'll have problems. Maybe if I move a bit, I'll feel tired quickly, or I'll feel fatigued. So it's in a way surprising. At the same time, it wasn't surprising, because we expect, what's not surprising there is that having muscle energy metabolism dysregulation correlates with having physical disability. At the same time, what is surprising is, at the point of discharge, we were not expecting them to have that, because they check all the clinical evaluations, they were okay. And when we feed those metabolites into a model, like machine learning model, on day one, we were able to segregate those that have good physical function from those that have poor physical function, but you can still see a high degree of overlap here, which means measuring their metabolites at day one of admission cannot completely or reliably predict if after discharge they will have physical disability or not. At day 5, also, we have a significant degree of overlap as well between those with good physical function and those that go on to have poor physical function. Meanwhile, at discharge, we have almost complete separation of those that have good physical function from those that have poor physical function. This small area of overlap is actually there so as to avoid overfitting the model. So it means that if we measure the metabolomic profile, the metabolomic profile of acute respiratory failure patients just before they are discharged from the hospital, that can actually guide physicians on how to advise them that, oh, down the line, you have a high probability of having physical disability, and based on that, you can take this medication, you can do this exercise, prescribe physical therapy or supplements that can actually help them to improve their bioenergetics. So this is an example of how you can gain rare insight into disease mechanism of patients and be able to apply it to real-world problems. And thank you very much for listening.
Oh, wow. Thank you very much, Professor Haastrup Adeyeye. This is massive. It's a round of applause. Let's use the reaction button to express our appreciation for this. I don't know how to describe the information that Pharm Adeyeye Haastrup has discharged within these few minutes. You have done very well. This is, and yeah, of course, like you just took a microscope and you just went to town and gave us all the details, especially for those of us that are newbies to metabolomics. That's a chemical microscope of health and disease. And in fact, of course, questions are already coming up on the chat box in reaction to the presentation. You have talked about so many things, the human microbiota, studying immune system, organ-specific metabolism, how the brain uses glucose during rest, even though I guess, I don't know if it was from my end, there was some network glitch. So I didn't get all of that at that point, but that's interesting. Characterization of vitamins, hormone regulation, and all that. And then the part where you spoke about taking table water, plastic bottle water, at the end of 1 year, you probably would have ingested between 39 and 52,000 microplastics. That's big information. I think we need to start to caution ourselves about that. And then talking about acute respiratory failure, the trimethylamine being produced in the guts, and how it can result to cardiac or respiratory issues. In fact, thank you very much, Pharm Adeyeye. You have done very well.